Thank you so much, Mr. and Mrs. Daniels. You've already covered quite a lot of that, and I think in this room are a lot of, I'm assuming you're all here because you're already engaged with some point of implementing respect, and so you probably know a lot of the background already. We had a discussion about whether some of these slides had already been seen before at the Resuscitation Symposium and so on, and I will go through some of them very quickly. They're here partly because there are a few people in the room that won't have seen them before, and partly because this is going to be a resource for anyone who wants to look up at them. So apologies, because a couple of them you have seen, but I will be very quick with them. So I think this slide you haven't seen. This is really just to emphasise what respect is about. And Mr. and Mrs. Daniels emphasised it is to absolutely ensure that patients get the care and outcomes they value. We as clinicians, patients, everybody can share that desire. And we can do that by encouraging patients to think about and communicate what outcomes they value and which ones they fear. It's not just about what we're not going to do, it's about what we are going to do. Facilitate clinicians to make and record the recommendations for care and treatment based on these patient preferences. There's some feedback. Can you guys, is it weird? It's all right. And then, and this is where the acronym comes in, ensure that the clinical recommendations are summarised in a plan for emergency care and treatment. And that then, that documentation, whether it be in paper form or electronic form, which we will discuss this afternoon, is recognised throughout all care settings. So that's really the summary, and I think everyone in this room is on board with those desires. So the question is, how do we get there? Or how did we get to this point, and how do we go there from now? So this is definitely something you've seen before, but just for reference, DNA CPRs weren't routinely completed. There were therefore inappropriate resuscitation attempts. People were bad at discussing it, and therefore some people didn't. They were misunderstood to mean that other treatments shouldn't be given. There is a multitude of different forms. And there was a difference in care with patients who had a DNA CPR sometimes getting less care because it was assumed that do not resuscitate meant about to die, when actually it should have just meant do not resuscitate. So we know that patients weren't being referred to ICU, ICU doctors weren't necessarily coming to see, and so on and so forth. There was obviously also a changing legal framework, so everyone is familiar with the Tracy case, but as a recap, in 2014, it was stated that because a DNA CPR decision potentially deprived a patient of life-sustaining treatment, there should absolutely be a presumption in favour of involving the patient, and to not discuss it with the patient would be in breach of Article 8. And this put the DNA CPR really in the limelight because people didn't really like discussing them and they didn't like completing them. They were all about the treatment not to be given. So it was another impetus in saying, well, how do we change this approach? How do we make it more about what the patient values and then what clinical recommendations could be given? It also brought up a huge debate in the medical professions, because there were a lot of people that said, well, a patient can't just demand to be for DNA CPR, and we don't want to end up in a world where a patient is asking, where we're offering a patient a menu of, would you like dialysis or not? Would you like non-invasive ventilation or not? That's not really what it's meant to be. And so, and then Winspear followed that, which is obviously that if a patient doesn't have capacity, then you shouldn't make a holding decision. You need to discuss with people close to them as long as it is practicable and appropriate. So we said there was an ethical imperative to stop using DNA CPR. There was a pragmatic, legal drive for change, but what were we going to replace it with? And how are we going to test it? So as you are also aware, we have been, and this is really what I want to emphasise now, and then try and bring us all together at the end of the day, and I think this is the strength of the conference. We were a collaboration of the willing. We had stakeholders from every different speciality, from all over, all 4 nations. We tried to pull together all of the best evidence. We had a public consultation. We had the support of the Resuscitation Council. See, now I'm going to get it wrong. Something else, Resuscitation Council UK. We've usability tested it. And we are in the process of doing a big evaluation in 5 sites. You're all familiar with the form itself. But the main point is to first establish shared understanding of the current situations, discuss preferred and feared outcomes, and then record the treatments record the recommendations that clinicians feel will help achieve those outcomes. So as we've said before, it's a change of culture. It's a change of culture in all of us. The fact that you're all here now suggests a commitment to that change of culture. The question, as Mr. and Mrs. Daniels said, is how do we then extend that so that we can really change the conversation, change the way things are discussed and recorded, and when do we engage with the public? You know that we launched the website with all of the materials. There are articles that are available I think you've seen the Learning app. Out of curiosity, how many people have seen the app? Has anyone not seen the app? Okay, so that's good access to it. We now have a certificate. It's not yet linked. I don't know how we're going to work out linking with all of the different hospital education certificates, but at least there's a certificate that you can download. There's several hospitals that have implemented. We're obviously all representing all of those hospitals that are in the process of doing it. And what we're hoping to engage people with now is a hub that, again, Resuscitation Council and YouGov, who've sponsored this event, have developed, which you all should have had invitations to, which should allow us to continue to interact, say what's working, what's not working, and continue to iterate it so that we can get from our good place that we're at to an even better place. And in doing that, we've adapted Section 6. We've simplified down the patient information leaflet with the help of Madeline, who I think is here somewhere. We've developed an easy read leaflet, an audit tool, and obviously the need for digital has been emphasised, and Peter Mark will be leading 2 workshops this afternoon. So I really just wanted to emphasise, thank you for helping us get here, everybody in the room, and we have developed Respect in response to evidence problems of DNA CPR. We are all driven by a desire to achieve better patient care, but it is absolutely dependent on continued engagement, continued feedback, and us being responsive. So please join the hub, email us, and we're all around today. Please ask questions, come and approach all of us, and really looking forward to meeting you and hearing from you later.